In this PowerPoint, we're going to review hypertension. And so hypertension, there are a lot of modifiable risk factors that can help to prevent coronary vascular disease. As blood pressure increases, so does the risk of myocardial infarction, heart failure, stroke, renal disease, and retinopathy. Hypertension affects about 46% of adults in the United States, and heart disease associated with hypertension leads to about 23.7% of deaths in the United States. The National Health and Nutrition Examination Survey indicated that 83% of people greater than age 20 with hypertension are aware they have high blood pressure. 76% of those are being treated, while 48% of those aware do not currently have their blood pressure well controlled. Blood pressure is the force exerted by blood against the walls of the blood vessels. It involves both systemic factors and peripheral vascular effects. It's important to maintain tissue perfusion during activity and rest, and the function of the cardiac output and systemic vascular resistance affect this. Cardiac output is stroke volume times heart rate. Normal blood pressure is a systolic less than 120 and a diastolic less than 80. Elevated blood pressure is considered when there's a systolic between 120 to 129 and a diastolic blood pressure above 80. Hypertension stage 1 is systolic 130 to 139 or diastolic 80 to 89. And hypertension stage 2 is a systolic greater than 140 or diastolic greater than 90. And that hypertension stage 1 is relatively new. We used to consider that normal blood pressure, but we now realize that that beginning stage can lead to issues as well. Primary hypertension is also known as essential or idiopathic. It accounts for the most of hypertension, about 90 to 95%. And this will be our primary focus in Nursing 353. There are many contributing factors, such as endothelial function related to either vasoconstricting or vasodilating agents, increased sympathetic nervous system activity, overproduction of sodium-retaining hormones, increased sodium intake, greater than ideal body weight, age, family, history, gender, race, diabetes, physical activity, stress, tobacco, and alcohol use also affects hypertension. Secondary hypertension is when there is a specific cause that can be identified and corrected. And with secondary hypertension, the goal is to treat the underlying cause. This only accounts for about 5 to 10% of hypertension in adults, and it's often suspected in those who suddenly develop hypertension. Examples of secondary hypertension: cirrhosis, drug-related, endocrine disorder, neurological, pregnancy-induced hypertension, renal disease, and sleep apnea. Non-modifiable risk factors are things that cannot be changed, such as age. Gender. Men, it's more common before middle age, but women, their incidence of hypertension increases with oral contraceptives. Preeclampsia, possible early sign. It's more common after menopause for women and harder to control. And after age 64, it's more prevalent in women. And of course, if there's a family history of a close blood relative, that increases the risk as well. Race is another non-modifiable risk factor. All ethnicities, 3 factors for decreased prevalence of hypertension: born outside of the U.S., do not speak English, or limited time living in the U.S. Blacks have the highest prevalence and more resistant to hypertension, tends to develop at a younger age, and females greater than males. There's more nocturnal non-dipping blood pressure, and what that essentially is referring to when the blood pressure at night falls less than 10%, more end organ damage, and highest death rate. There is less response to renin-inhibiting medications, better control with calcium channel blockers and diuretics, and there is a genetic component with angioedema with blacks when taking ACE inhibitors. It is 2 times higher in blacks than whites as far as for hypertension. Hispanics are less likely to receive treatment they have a lower rate of awareness and treatment and control. Now, modifiable risk factors are where we really need to focus our efforts as nurses. These are the risk factors that can be changed, so such as an unhealthy diet, eating excess dietary sodium. Although only 1 in 3 people who consume high sodium actually develop hypertension. Physical inactivity, so regular exercise, can help control weight and reduce cardiovascular disease risk, and it may lower the blood pressure. Obesity, weight gain is associated with increased frequency of hypertension, and risk increases with central abdominal obesity, so more of those apple-shaped people. Excess alcohol intake is strongly associated with hypertension. Therefore, we really want men to limit to 2 drinks a day and women 1 drink per day. And tobacco use increases the risk for coronary cardiovascular disease. And when people have a history of smoking, they're more likely. And think about how nicotine works. It causes vasoconstriction. So if we constrict those vessels, then the heart has to work harder to get that blood out. And then repeated stress may cause development of hypertension. Other risk factors are people with lower socioeconomic groups and less educated. Diabetes. Hypertension is more common in patients with diabetes. And when a patient has hypertension and diabetes, the target organ damage will be more severe. Hyperlipidemia is more common in people with hypertension, and increased levels of cholesterol and triglycerides are primary risk factors for atherosclerosis, which is that buildup in our arteries and veins. So one of the big things we really want our patients to understand is that hypertension is basically asymptomatic. Patients aren't really going to have symptoms of blood pressure, which may be part of the reasons why patients don't take their medications or get it really well controlled. And they're not going to have those symptoms until there's target organ disease occurs. Other symptoms of severe hypertension include fatigue, dizziness, palpitations, angina, and shortness of breath. So again, the complications of hypertension are based on that target organ damage. So with the heart, that's going to be coronary artery disease, atherosclerosis, left ventricular hypertrophy, and what that means is that left ventricle is large. And unlike with bodybuilding, a big muscle is not good with our heart. Heart failure, brain, there can be cerebrovascular disease, TIAs, and strokes secondary to the atherosclerosis. There can also be hypertensive encephalopathy and changes in autoregulation. And then peripherally, atherosclerosis leads to peripheral vascular disease, aortic aneurysms, aortic dissection, and intermittent claudication. But target organ damage doesn't stop there. The kidneys also are often affected, and it causes nephrosclerosis leading to chronic kidney disease. The eyes end up with retinal damage, which can lead to blurry or loss of vision and retinal hemorrhage. And damaged retinal vessels indicate concurrent damage to vessels in the heart, brain, and kidneys. So what diagnostic studies can we expect with somebody with blood pressure? We're going to be doing that basic metabolic panel, that renal function, urinalysis, CBCs, lipid panels, uric acid levels, ECGs, eye exams, possibly echoes, liver function test, and TSH, which stands for thyroid stimulating hormone. We want to identify and rule out secondary hypertension, and the reason we're doing all those other tests is that we want to evaluate target organ disease. We want to determine if cardiovascular risk, how high it is, and establish our baselines before starting therapy. And then there is that where we have patients check their blood pressures at home, and so they get a blood pressure monitoring device, and that helps to avoid that white coat hypertension. So white coat hypertension occurs when blood pressure readings at the doctor's office are higher than they are in other settings, such as the patient's home. Non-invasive, again, that fully automated system, and you're going to teach the patient to hold their arms still while the device reads blood pressure and keep a diary of activities when they do that at home. So our goals with hypertension is to achieve and maintain goal blood pressure, reduce our cardiovascular risk factors and target organ disease, and lifestyle modifications. And the AHA, the American Heart Association Life Simple 7. So manage blood pressure, control cholesterol, reduce blood glucose, get active, eat better, lose weight, and stop smoking. Weight reduction of 1 kilogram can decrease the systolic blood pressure by 1 millimeter of mercury. And that can happen through calorie restriction and physical activity. The DASH diet, which stands for Dietary Approaches to Stop Hypertension, includes eating fruits, vegetables, fat-free or low-fat milk and milk products, increasing whole grains, fish, poultry, beans, seeds, and nuts. We also want to teach about dietary sodium restriction. So for healthy adults, we ideally want them to have less than 2,300 milligrams per day. And for those who are blacks, middle-aged, older, people with hypertension, diabetes, or chronic kidney disease, we want them to have less than 1,500 milligrams. And so some of those things to think about are the salty six, such as breads, rolls, lunch, cured meats, sandwiches, pizza, soup, and poultry. So we really want people to read their labels, watch their over-the-counter medications and health products such as toothpaste with baking soda. Other lifestyle modifications, as we talked about, 2 drinks per day for men, 1 drink per day for women, increasing that activity. So we really want people to be exercising 30 minutes of aerobic activity at least 5 days a week with a goal of 150 minutes per week. That should combine moderate and vigorous activities, age-associated guidelines, muscle strengthening activities at least 2 times a week, flexibility and balance exercises 2 times a week, especially in older adults, can help to decrease fall. Again, we want to teach patients to avoid tobacco products. Nicotine, again, causes that vasoconstriction. Smoking cessation reduces risk factors within a year. We want to help people with social determinants of health who have low socioeconomic statuses, making sure that they're getting resources to meet their needs. Emotional and social support systems. We want to help patients reduce stress at work and in family. Educational preparation, access to health care, safe housing, exposure to crime and violence, negative emotions, all these things can affect hypertension. The activation of the sympathetic nervous system and stress hormones increases the risk for hypertension, and we want to make sure that we're getting people to their resources. We want to teach about that target organ damage, that's the big thing that we're trying to prevent with hypertension. We're going to do screening programs, identify risk factors for hypertension and coronary artery disease, blood pressure measurements, health assessments, and medications and/or preventative treatment. So some of the medications that are given for hypertension include adrenergic inhibiting agents. These help to decrease the sympathetic nervous system stimulation. They work centrally on vasomotor center to peripherally inhibit the norepinephrine release or block adrenergic receptors on blood vessels. ACE inhibitors prevent conversion of angiotensin 1 to angiotensin 2, and it reduces vasoconstriction and sodium and water retention. Alpha-2 receptor blockers prevent angiotensin 2 from binding to receptors in the blood vessel walls. Calcium channel blockers increase sodium excretion and cause arteriolar vasodilation by preventing the movement of extracellular calcium into the cells. And then there are direct vasodilators, which relax vascular smooth muscles and reduce systemic vascular resistance. And then, of course, diuretics reduce our plasma volume by increased sodium and water excretion and reduce vascular response to catecholamines. Depending on the healthcare provider, patients with hypertension, it's usually going to be that non-pharmacological treatment such as weight reduction, exercise, stopping smoking, all of those other things we talked about, plus 1 first-line pharmacological medication such as thiazide diuretics, calcium channel blockers, ACE inhibitors, or angiotensin receptor blockers, ARBs. Now, a patient with stage 2 hypertension, again, remember that was at 140/90, We're also going to be doing those non-pharmacological therapy plus 2 antihypertensives from 2 different classifications. And if one drug is not tolerated, then another classification will be used. There should be monthly follow-up visits until at a goal blood pressure, then 3 to 6 months. Stage 2 hypertension or with comorbidities, patients should be checked more frequently. It's important to let the patients and family members know to report all side effects, that different medications can be tried if there are severe or unwanted side effects, and that will help to maintain that they have that adherence to therapy. Common side effects with our antihypertensive medications are orthostatic hypotension. So they're going to feel dizzy or fainting when changing positioning. The big thing is that we're going to teach them to dangle first. So remember that sitting on the side of the bed with their feet hanging off, especially monitor that first dose closely with any kind of antihypertensive. So, if I have somebody who I just gave a blood pressure medication to, and it's their first dose, I'm going to want to make sure that I, as the RN, am the one to get that patient up to make sure that they do okay. Sexual problems such as reduced libido or erectile dysfunction also may happen, and so patients may stop taking their medications. Dry mouth, we can encourage sugarless gum or sugar-free candy. And again, if they are on a diuretic, it could cause frequent voiding, so we want them to take that early in the morning to try and keep them from getting up at night. So thiazide diuretics, hydrochlorothiazide, is one of the first-line medications for hypertension. Orthostatic hypotension, hypokalemia are things that you might see. And actually, it's not on this slide, but you're more likely to see hyponatremia, so that low sodium with thiazide diuretics. NSAIDs can increase the diuretic and antihypertensive effect, and we would teach them to eat potassium-rich foods. Now, loop diuretics like furosemide also can cause that orthostatic hypotension, hypokalemia. We want to teach them those potassium-rich foods. They may need supplements. And with this, we're going to monitor potassium, BUN, creatinine, and urine output. Of course, there are some potassium-sparing diuretics, such as amiloride, that also can cause orthostatic hypotension and hyperkalemia. We want to avoid potassium supplements. Aldosterone receptor blockers such as spironolactone also can cause that orthostatic hypotension and hyperkalemia. We want to be careful not to combine this with potassium-sparing diuretics or potassium supplements. And with these, the other thing with the potential for the hyperkalemia is to be careful with those salt substitutes. Remember, those are made of potassium chloride instead of sodium chloride, and so we would want to teach the patients to be careful with those. Clonidine is a central acting alpha-adrenergic agonist, and sudden discontinuation can cause withdrawal, rebound, hypertension, tachycardia, headache, tremors, apprehension, and sweating. We'll have them take hard candy or chewing gum for the dry mouth. And we want to be careful with alcohol and sedatives because it increases sedation. And then alpha-adrenergic blockers, doxazocin, want to take that at bedtime to help decrease that risk for the orthostatic hypotension. So beta blockers. Cardioselective beta blockers like atenolol, metoprolol, we definitely need to monitor our blood pressure and heart rate prior to and after. If I have a blood pressure less than 100, I need to be questioning whether I should really be giving that. A heart rate less than 55 generally is going to be a hold, and sometimes even under 60 will hold for that. Non-cardioselective, such as propranolol, we also need to monitor blood pressure and heart rate. Same things. If I'm under systolic of 100, I should be questioning whether I'm giving it. Heart rate less than 55, generally I'm not going to be giving that. I need to talk to the healthcare provider. And with propranolol, this is not recommended in patients with asthma because it can cause the bronchospasm because it's not cardiac selective. Now this can be mixed with alpha and beta blockers such as carvedilol. This one also, again, blood pressure and heart rate need to be monitored questioning if we're giving it for the systolic less than 100. And this one, carvedilol, this is one of the ones where usually 55 is our kind of hard hold. And then labetalol, this is also a beta blocker. We can get this IV for hypertensive crisis. Want to keep the patient supine, monitor for severe orthostatic hypotension. And again, if I'm giving IV labetalol for hypertensive crisis, this patient is probably in the intensive care unit and not a regular floor. Medications that are direct vasodilators are hydralazine, nitroglycerin, and sodium nitroprusside. Sodium nitroprusside is an IV form for hypertensive crisis. You have to use it in a pump, and that person is going to be in the ICU. So the big thing I want you to know about sodium nitroprusside is it's going to be for hypertensive crisis, ICU, and we're going to be monitoring that blood pressure, and it has to be on a pump. Now, angiotensin converting enzymes, ACE inhibitors, notice those ends in pril. And so captopril, enalapril, lisinopril. Captopril can be given orally during a hypertensive crisis. The others are medications for hypertension. I see lisinopril given a lot for hypertension. Aspirin and NSAIDs may decrease the effectiveness of this. Adding a diuretic enhances the effect. It's not that with a potassium sparing though. And we're going to, of course, watch for elevated creatinine. ACE inhibitors are hard on kidneys. There's also that typical side effect of that cough. Some people will call it that cat cough. It's a dry hacking cough. It can happen anytime in treatment, and it's so severe that patients will stop taking the medication. So if somebody ends up with that dry cough, it may end up showing up as a allergy to the medication where it's really they're not able to take it because it just keeps them from being able to have a quality of life. Again, monitoring for angioedema, that is a higher risk for our Black patients. And ACE inhibitors are used to help protect the kidneys, especially patients with diabetes. But at some point, that medication can just kind of change and start becoming harmful to the kidneys. So that may be a little weird thinking that it's used protectively for the kidneys, but then it can also harm the kidneys. So that's why we're monitoring that BUN and creatinine. So angiotensin II receptor blockers are ARBs. Losartan is an example of those, indensartan. It may be one of the first line medication for hypertension. It's a great alternative if somebody ends up with that cough from the ACE inhibitor. Calcium channel blockers, also another potential first line of medication for hypertension. Diltiazem is also available in extended release. Verapamil. With verapamil, grapefruit juice can increase the drug concentration, so they need to avoid it. Other calcium channel blockers, amlodipine or nifedipine. Nifedipine IV can be given for hypertensive crisis. We used to give that sublingually, but that's not considered safe and effective. We used to get a lot of rebound hypertension with that, so that's not a typical medication that we give sublingually anymore. So when we're assessing somebody with hypertension, we want to ask about their past medical history, their hypertension, cardiovascular, do they have any cerebrovascular, renal, or thyroid disease, diabetes, pituitary disorders, overweight, high lipids, menopause, or hormone replacement. We want to check and see what medications they're taking, not only prescription, but over-the-counter, herbals, or illicit. And then subjective data, their functional health patterns. We want to see how do they feel like they're doing. Are they smoking? Do they drink? Are they sedentary? How is their literacy? What's their nutrition like? Have they gained or lost weight? Are they getting up in the middle of the night to urinate? How are they able to exercise? Are they fatigued? Do they have dyspnea on exertion? Do they feel palpitations or chest pain? Or do they have any dizziness, blurred vision, or paresthesias? Want to ask about erectile dysfunction or decreased libido. And then the coping. How are they tolerating stress and stressful events? So from our objective data, we're going to obviously do blood pressure readings, checking for orthostatic changes, listening for abnormal heart sounds of S3 or S4, checking pulses, whether they have edema, checking body measurements, what's that abdominal girth, assessing the mental status, and then any diagnostic study results. I'm sure you all remember how to do a blood pressure. Ideally, we want the patient to not smoke, exercise, or have caffeine 30 minutes prior to the blood pressure, resting quietly for 5 minutes, no talking. The cuff size is important for accuracy. We want the position of the arm at the level of the heart. We're going to listen ourselves, and we want to deflate by 2 to 3 millimeters of mercury per second. And we should take in both arms, noting differences, and use the arm with the highest blood pressure for future. If we can't use the upper arm, then we'll use the forearm and listen with a radial artery or a Doppler. And obviously, we're going to document our sites. And obviously, we should clean the cuff between patients per our agency policy. We should assess for orthostatic hypotension, and the big thing with orthostatic hypotension is it's not just blood pressure. You have to have blood pressure and heart rate to really get whether somebody is orthostatic. So you're going to have them lie for 5 minutes. You'll assist them to a sitting position and check it, blood pressure and heart rate. And then we'll also have them go to a standing position and check that blood pressure and heart rate. Normal is there is a systolic blood pressure decrease less than 10 millimeters, with the diastolic blood pressure and heart rate increasing slightly. Abnormal if there's a systolic blood pressure decrease within 20 millimeters of mercury, or diastolic blood pressure decreased 10 millimeters of mercury or more. And the heart rate would increase 20 beats or more, and the patient will usually report symptoms of lightheadedness and dizziness. So when patients are in the hospital, we're going to check the blood pressure, monitoring the vital signs. We're going to look for effects of the drugs, but the big thing is always to trend our vitals. Patients with persistent increased blood pressure should be evaluated for hypertension and follow up with a healthcare provider. And we want to refer them to dietitians, possibly physical therapists. There are screening programs in the community. We may give them a blood pressure reading and writing, explain the need for further evaluation in that. And we want to focus on control for those who have hypertension, identify risk groups with cardiovascular risk modification, lifestyle modification, and screen those with limited access to care, and connect them to a healthcare provider or insurance if needed. In the outpatient basis, we want the patient to help reduce their blood pressure. Again, evaluating if the medications are effective, detect and report adverse effects. We want to assess and enhance adherence, teach the patient and caregiver about nutrition, medications, lifestyle modification, and how to check their blood pressure at home. So again, home blood pressure monitoring, we want to teach that patient, want to make sure that they know how to put the equipment on correctly, how frequent to do it, and when to report. Want to teach them what their target blood pressure is and reinforce adherence to their blood pressure medications and checking it. Teach them about lifestyle changes to help reduce those complications. And they need to know their medications, the purpose, side effects, what to report, precautions, and not to double or skip or stop abruptly those medications. So like TB, patient adherence can be a major problem with hypertension. Some of the reasons for poor adherence are inadequate teaching, low health literacy, unpleasant side effects of the medications. Their blood pressure may return to normal, so therefore they think it's fixed, not realizing it's the medication that's actually doing that. The high cost of medications, lack of insurance, and things that we can do to help enhance compliance are individualize their plan, get the patient as an active participant, make sure that we are picking those affordable medications, like Kroger and those have like $4 medications, involve caregivers, combination medications, and again, that patient teaching. Of course, our goal is for the patient to achieve and maintain the goal blood pressure. We want them to understand, accept, and implement the treatment plan, and hopefully they'll have minimal side effects to the therapy. I just briefly want to talk about hypertensive crisis. A hypertensive crisis is when a patient has a systolic blood pressure greater than 180 and or a diastolic blood pressure greater than 120. That is a hypertensive emergency. We can see target organ damage quickly. It does require hospitalization, and there can be some very severe problems if prompt recognition and treatment is not obtained. Encephalopathy, intracranial or subarachnoid hemorrhage can happen, heart failure, heart attack, renal failure, dissecting aortic aneurysm, or the vision issues with retinopathy. If untreated, there's a 79% mortality in 1 year. Usually there's a history of hypertension and they've either been non-adherent or under-medicated. They could also be using other medications such as cocaine, amphetamines, PCP, LSD, which can lead to seizure, stroke, myocardial infarction, or encephalopathy. So if they have the hypertensive encephalopathy, they may be complaining of a headache, nausea, vomiting, may have seizures, confusion. They may go into a coma, retinal changes, renal insufficiency. We're going to see that decreased urine output, increasing BUN and creatinine, or decreasing GFR. Cardiac decompensation with an MI, heart failure. They may end up with pulmonary edema, chest pain from the heart attack, shortness of breath. And with aortic dissection, depending on where it is, they could have chest or back pain and reduced or absent peripheral pulses. And we'll talk more about aortic dissection later on. So again, somebody with hypertensive crisis, it is an emergency. We need to treat related to the blood pressure, and based on the evidence of target organ disease, we're going to give IV medications to slow titration, trying to get that MAP, mean arterial pressure, of 110 to 115. And the way we do MAP is you do systolic blood pressure plus diastolic blood pressure times 2 divided by 3. And our machines automatically do that for that. But when somebody has a really high MAP, we want to bring that down slowly. If we bring it down too quickly, we can actually cause them to stroke. One of the big medications we would anticipate giving is sodium nitroprusside, which is a vasodilator. Again, this has to be given in the ICU. They might also get adrenergic inhibitors, calcium channel blockers. The medications have a rapid onset, so we're going to be monitoring heart rate and blood pressure very frequently, every couple minutes. Special considerations are the risk for, again, that aortic dissection, acute ischemic strokes, or post-stroke patients. We're going to monitor cardiac and renal function, neurochecks. They're going to be on bed rest if they have IV medications. We're going to be trying to determine the cause and education to avoid future crisis.